Thanks so much for the kind introduction, and it's a great opportunity to following Dr. Muhammad's talk on to actually share some experience with the preliminary experience with the use of the new IDF DAR risk calculator in our part of the world. And so in my hospital Putrajaya, which is a tertiary hospital in the public service and dedicated to endocrinology services, quite quickly after the launch and introduction of the IDF DAR Calculator 2021, which was actually in January last year during the same conference, the first DAR Asia conference on 9th DAR International Conference, and there in the following weeks was a training of the trainers in the Asian region organized by the IDF and Dar International Alliance. And following that virtual training, all of us were asked to actually see how we could actually apply the new risk calculators in each of our practices. So what we did in our hospital is attempted to actually use this new tool in our patients for Ramadan 2021. So as a background, we've already understood generally that diabetics who fast may face considerable risks depending on their various factors. And the risk stratification is most important because ultimately it's actually identifying in the pre-Ramadan period which patients would be at risk of developing complications such as severe hypo or hyperglycemia, and which may necessitate hospitalization. And this is what we want to prevent by having good education of the patient as well as treatment adjustments appropriately. We've already understood with regards to the evolution of all the prior risk stratification systems as alluded by Dr. Muhammad Hussein from the previous guidelines of 2005 and then 2010 and also the 2016, and realized that in these guidelines risk stratification was not very much individualized or objectively considered. So an attempt was made to actually review this and create a new tool which was trialed and then validated in a way between the experts and then rolled out and it was available in the publication last year. So this was the prior guidelines. I think you've already, some of you were using it before the most current one, and we can see the broad categorization of risk into a very high risk, moderate, and low risk, depending on all those parameters. And that very likely an individual could have an element of each of those categories, but so it would be very difficult to place their exact risk. And the weightage of each element was not considered individually. There was a mention also that special populations were generally not advised to fast, and these were type 1 diabetes, those who were elderly and frail, and those who are pregnant. But we understood in real life practice that there were individuals who were able to fast safely in these special groups. So as such, we've heard a lot about the IDF DAR guidelines of 2021, and it was really welcomed because there was a need for a tool that took into consideration the different elements and gave weightage separately to all these different elements, and that could then be incorporated into a risk calculator, which would then give a score, and depending on the score could risk stratify the individual and therefore give the physician the appropriate recommendation for the individual to fast or not to fast, or therefore to address certain issues, particularly education of the patient and treatment adjustments. So we are familiar with the fact that there are different factors that need to be taken into consideration when deciding the risk, as already mentioned in the previous talk. And you have also seen that these are the 14 elements that make up the risk calculation, and within each domain, depending on what the patient has, and a score would be put on it. And certain, as we can see, certain elements have far greater weightage than others. And the resultant score can then actually be be calculated, and then the patient placed into different risk categories, and then the broad recommendations according to these risk categories about fasting, or actually to advise against fasting. This is the concept is not new to us, but this is a much more objective way of making the decision. So our objective in a survey to present to you very quickly is to assess the performance of this new risk calculator, the scoring and stratification system among patients attending our diabetes clinic in Malaysia in Putrajaya Hospital, and see how the patient's intention to fast, how that actually match with the recommendations that the physician would give based on the new risk stratification, and then also to see how the user, the physician applying the tool, actually found it, how acceptable it was for them to use it. So this was observational and a cross-sectional study. I had the privilege to listen to two other studies presented in the last 2 days, which was a prospective study, looking into how the risk calculator then impacted onto the outcome of Ramadan. But we just used it in the beginning to look at the applicability in our outpatient diabetes clinic. And these consisted of 6 clinic sessions between early March to early April. As we know, Ramadan was in, following that April to May, and 2021. So we got the patient's demography and diabetes profile, which was available from their electronic medical records. We had a hard copy. We did not have a soft copy or app at that time to calculate the DAR, but we had the hard copy done, and we scored it on a sheet and stratified it. The doctors were trained to do that, and the patient was then asked about their intention to fast. And at the end of this study, also we surveyed the physicians that use the tool, and to see how acceptable it was by performing, a 6 questionnaire of 6 questions, and an open-ended question for the feedback. So we had 210 patients. Their mean age was about 54. About 60% were female. And as you can broadly see, according to each of the elements assessed in that risk calculator, if we look at type of diabetes, 94% of the patients were type 2 diabetes. We only had one type 1 clinic during that 5-week period because we have a monthly clinic. And being a tertiary hospital, we're actually seeing patients with, longer duration of disease and comorbidities and complex, conditions along with their diabetes. So they had more than 10 years of diabetes in 70% of them. And also because of the setting of our diabetes clinic, we were also seeing more people on insulin, about 70%. Here are also sharing with you the other results from the other elements of the risk calculator. When we look at the presence of hypoglycemia, we are aware that 70% are on insulin, but the great majority did not have any hypoglycemia at all, as we can observe here. 150 of the 210 patients. Very, very few patients had hypo unawareness, or even severe hypo, just 2 and 5 of them here, as you can see. So hypoglycemia was not at the baseline of the study. And when looking at level of glycemic control, we can also see, according to the broad classification, that the majority had A1Cs above 7.5%, as seen here. And going on to their glucose-lowering medications, probably typical of a tertiary hospital setting. We already mentioned about most of them being on insulin, and mostly on an intensive insulin regimen. If they were on insulin, on basal bolus insulin regimen, about 40% of them. And if they were on oral agents, as we can see from the chart, most of them who were on oral agents, about a third of them, most of them were on 2, 3, or more oral anti-diabetic combination therapy. And we have elaborated about the medications is another way of looking at it. But just to remind us also from the scoring system, how each medication played weightage to the risk score, yeah, where pre-mixed insulin would have a weightage of 3 for the score, and basal bolus of 2.5. So we could see that most of our patients were either on mixed insulin or basal bolus, making them already have that weightage for their eventual risk score. In terms of SMBG, we recognize that still about half of the patients are not performing SMBG as indicated. And this is still a problem in Malaysia, where even people on insulin are not doing SMBG regularly. So this would also give some weightage to the score. Most of, or almost all, did not have a recent complication, whether of severe hyperglycemia, as observed here, DKA or HONC. And if we look at the macrovascular complications and comorbidities, again, being patients with longer duration of disease, a fair proportion did have some microvascular disease, but mainly they were stable. So very, very hardly any had unstable complications or comorbidities. In terms of renal complications, again, mainly in the main diabetes clinics, most of our patients had a satisfactory renal function, and very, very few had more extremes of renal dysfunction, and no pregnant patients in this. We have a separate combined clinic to see diabetes and pregnant patients. So that may be an area which we should test the risk calculator. So a reminder again about how the different parameters, for example, renal complications and the stage of their diabetic kidney disease, or the absence or presence of pregnancy, will give weightage to the scoring in this new risk calculator. Also of importance is the frailty and cognitive function. And here we see in our little cohort of patients in our clinic that the majority are actually not having the issue of frailty and cognitive dysfunction. So that did not contribute to their risk scoring. And in terms of physical labor, Putrajaya, where we are, is the administrative capital, and a lot of people are working in the offices, and not many out there doing heavy physical work. So that explains the result here. Many people have had diabetes for a long time, and therefore they have been fasting with diabetes, and therefore they've had already been educated and familiarized with what to do during their Ramadan period, whether they are fasting or not, with their diabetes medication. So many had actually a positive experience from the previous Ramadan. Yeah, so these two elements did not have so much weightage in the entire risk scoring. So I've actually presented to you the different elements. So it gave us an idea of our patient profile. So at the end of it, the scores were actually calculated, and what we found in our patient is that we had this distribution of those with high risk and moderate risk, making up about almost 75%, or 3/4 of the patients that we see in our outpatient clinic, which we should recommend, against fasting because of their risk category. But as we expected, the overwhelming majority, when asked whether they intended to fast despite their risk stratification, still would intend to fast. So 81% of the high risk patients would fast, and almost absolutely all of those in the moderate risk patients still intended to fast. And all except one of the 17 patients in the high risk who really did not intend to fast. It would be great to actually do a prospective study to see how those who intended to fast despite their risk category, how they completed their fast, and whether they had issues with hypo or hyperglycemia. So these are the type 1 diabetes profile. I mentioned we had about 13 patients only, which was 6% of the entire cohort of patients. And of course, just being type 1 diabetes and having insulin on board would already identify them into the moderate and high risk group. Insulin use was probably or the greatest factor that contributed to whether someone would be placed into a moderate or high risk category, as we can see here. So if you were on insulin, if you were on more complex insulin regimens, for example, base-bolus insulin or premix insulin, then you would already be placed in the high and moderate risk based on your total risk score, compared to if you were on an oral based glucose lowering therapy. The user acceptance survey looked into the physician's perspective of how they knew Dar risk calculator provided them with a more objective assessment of compared to the prior risk stratification tool, and also how easy and convenient it was to use in a busy clinic, and whether they were confident to actually use the risk stratification and what the recommendations that followed it was, and also to also see whether their patients who they attended to were willing to accept their advice if they had to advise them against fasting, if the risk stratification was moderate or high risk, and whether they would be keen to use the risk calculator subsequently in the following Ramadan. So these 20 individual healthcare professionals were used the risk score and were asked the user acceptance survey, and you can see quite clearly and broadly that most agree and strongly agree that the risk, this new risk tool was more objective compared to the previous, and comprehensive, was easy and not really time consuming. They could use it confidently in their patients. But as we can see here in question number 5, they found that there was some disagreement that the patients would follow their advice when they, as recommended, following the risk stratification. And this is always a challenge for us. We would give the patient advice according to their risk, but whether they accept it is another issue. So this is where patient education will come in. So this is just a summary of the results of the survey in point form about the acceptance, generally good acceptance by our healthcare professionals in our unit to using this new risk calculator there. And so we are very keen to actually go ahead to use it in the subsequent Ramadan, and maybe focus on probably some populations, for example, those with renal disease, pregnant patients, and particularly also type 1 diabetes. So as a conclusion, ladies and gentlemen, I think I've just presented to you some preliminary experience of us locally in Malaysia using this IDF risk calculator, and I'd encourage you to actually use it in this coming Ramadan, and see how it can actually help you actually look into specifically and objectively stratifying your patients, and therefore also being able to make the right recommendations as well as institute the right patient education and treatment adjustments for your patient. Thank you very much for listening.